presentation on inborn errors in metabolism. So the clinical presentation of metabolic disease is non-specific problems with lethargy, decreased feeding, vomiting. These symptoms can progress to seizure or coma, but these symptoms are very similar to a lot of other things that can happen to a baby, including congenital heart defects, sepsis. While most of the disorders that I'm going to be discussing in this presentation are tested for on Illinois newborn screen, every state has a different group of disorders that they test for, and this is the reason you will never be asked what's on a newborn screen on a step exam. So newborn crash, this is usually a term infant with a well interval. The placenta is filtering the fetus's blood before it's born. So before it's born, if it's missing an enzyme, his mom, well, most of these are recessive, has at least one copy that's working, so she's filtering whatever these byproducts that the baby can't, because the blood gets filtered by the placenta, and then you cut the cord. And now things start accumulating. So there's non-specific poor feeding, vomiting, lethargy, and these can progress to seizure and coma. Occasionally there's an abnormal odor to the urine. We're going to talk about urine odors because, one of the things, my goal of this presentation is that you're not afraid of metabolic questions. We're going to go through a bunch at the end. It seems like overwhelming amount of material and really confusing, but I want to try to make it as easy as possible, which is impossible. We're going to try. So the differential of a newborn crash is, the first thing, the second thing, and the 10th thing you should be thinking about. If you have a baby who looks fine and now is going downhill and not eating, looks kind of punky, is sepsis. So when you have this baby, the first thing you should be doing is a septic workup. LP, CBC, starting on Ampigen, you should be doing those things. And maybe, seeing for signs of a heart disorder. But you need to think about other things. And if you don't think about them, you're going to miss them. Amino acid abnormalities, urea cycle defects, organic acidurias, mitochondrial disorders. Now, this is by far not a perfect diagram, but it's the best one I could find. So you have a baby with lethargy, maybe coma, seizures, vomiting, maybe an unusual odor. Are they acidotic? What's the HCO3? If they're acidotic, where's this acid coming from? Is it coming from lactic acid, either primary lactic acidosis with the mitochondrial disorders or secondary with the number, like coarctation of the aorta can cause some of the highest lactic acids I've ever seen, galactosemia, tyrosinemia, or is this acid coming from organic acids? If they're not acidotic, but they look horrible, what's their ammonia and urea cycles? And then if everything's normal, it still could be metabolic, such as like PKU. So, baby presents at 4 days of life. One of the things we're going to go over and over and over is how old were they that presented? 4 days of life, lethargy, decreased PO intake, a septic workup's negative. He's noted to have a blood gas of 7.49, and they give you the normals here. A pneumonia 1200, what is the most likely diagnosis? Ornithine transcarbamylase, maple syrup urine disease, MCAD, galactosemia, or phenylketonuria, or PKU. So you're like, I don't know any of these things. Anyway, so metabolic acidosis, decreased blood pH caused by the accumulation of hydrogen, decreased bicarbonate with excess HCO3 and H2CO3, decreased PaCO2 with compensatory hyperventilation. So the question is the metabolic acidosis the result of abnormal loss of bicarb in the case of diarrhea or the accumulation of acid? And the way we do this is the Henderson-Hasselbalch equation that measures the anion gap, plasma sodium minus Cl chloride plus HCO3, and normal is between 10 and 15. In metabolic disorders, there's an accumulation of organic anions. Clinically, there's usually a persistent acidosis that gets worse with decompensation. So, we're acidotic. If we have a normal anion gap, this is usually because of loss of bicarb, diarrhea, RTA. But if it's elevated, expanded anion gap, it's because of an accumulation of fixed acids. Now, if we're talking about a 10-year-old or a 5-year-old, then we're thinking ketoacidosis, diabetes, type 1 or type 2. But neonatal diabetes makes inborn errors in metabolism look common. So if this is a baby under a couple months of age, you should be thinking inborn errors in metabolism over ketoacidosis. So if this is a 5 or 10-year-old, you should be thinking this. So organic acidurias, there are many pathways and enzymatic defects that can result in this large group called organic acidurias. Clinical features usually include decompensation in the first 2 weeks of life. Glutaric aciduria can present later, and acidosis, elevation in anion gap, and elevated lactic acid can all be signs of this. So organic acidurias include methylmalonic, isovaleric, propionic, and glutaric aciduria. Clinical features: acidosis, hypoglycemia, bone marrow suppression, a little bit of neutropenia, hyperammonemia. The liver's unhappy, but it's not going to be as high as when we go to the urea cycles. Next thing I want to talk about is amino acidemias. And so amino acids, we have 20-something amino acids, and they're the building block of proteins, and they're essential amino acids, and the remainder are made from each other. And so various enzymatic defects result in the inability to convert one amino acid to the other. So phenylketonuria, or PKU, is the inability to convert phenylalanine to tyrosine through this enzyme phenylalanine hydroxylase. When you can't go from phenylalanine to tyrosine, it then gets shunted to phenylpyruvate, because it has to go somewhere, that then goes into a bunch of acids: phenylactate, phenylacetate, phenylethamine, phenylglutamine, and these are toxic to the brain. If untreated, infants may lose 50 IQ points in the first year of life. So they're born fine. Their mom, assuming a baby born with PKU, in most cases, the mom doesn't have PKU. But then, so she's filtering, but then you cut the cord and you start getting problems. It's inherited in autosomal recessive fashion. So clinical features, most babies are picked up by newborn screening, basically 100%. If a baby is not picked up by pre-symptomatic screening, some of the early symptoms of PKU include poor weight gain, microcephaly, a mousy or musty odor of the baby. So again, odors are really important. Management: a low protein diet, limited phenylalanine, and just enough phenylalanine to grow. Kuvan is a medication that can improve enzyme function in patients that have deficient but some enzyme activity. Restriction of diet sodas. And if you've ever looked at a Diet Coke, right there on the can, it'll say contains, aspartame is basically phenylalanine. So, you could kill somebody with this if they have PKU or hyperphenylalaninemia. And a lifelong diet is needed. They used to think if you just stayed on the low protein diet for the first, 5 years of life, you would be fine. However, they realized the brain is not completely done developing at 5, and these kids started having issues with ADHD and loss of cognitive function, and it's a horrible diet. Once you go off this diet, you're never going back on. So another thing, and this is actually a big board question, is mothers with very poor controlled phenylalanine levels. The mom that has PKU, a mom that has PKU can have babies with birth defects. Most of the babies don't have PKU because the dad wasn't a carrier. They have a good copy of the gene from the dad and a bad from the mom. But high phenylalanine levels are teratogenic to the baby. And I've looked over a bunch of board questions. Again, if a board question starts with "this child was born in a third world country and comes to the U.S. and is failure to thrive and has a mousy odor, blah, 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 blah." Most babies, basically 100% of babies in the U.S. are picked up on newborn screening, so you're not going to see that. But what you may see is the mom has PKU. She was not well controlled with phenylalanine during the pregnancy, And the baby's born with microcephaly, congenital heart defects, other kinds of issues. As I said earlier, the baby born with PKU is actually normal at birth. It's just that the phenylalanine causes birth defects over time because his mom was filtering this. The baby born to a mom with PKU actually is born with congenital anomalies and microcephaly because it was the high phenylalanine from the mom was actually teratogenic. The next disorder I want to talk about is homocystinuria. And homocystinuria is caused by the inability to convert homocysteine, and I want to point out EIN, to cysteine through this enzyme cystocyanine synthetase. As a result, the homocysteine goes to homocysteine, EIN to INE, and excreted as homocystinuria, so INURIA. The elevation of homocysteine in the blood results in a prothrombic state that also increases the risk of blood clots. It's inherited in autosomal recessive fashion, and unlike most inborn errors of metabolism, they actually have some dysmorphic features, including long fingers, tall stature. They can have hypermobility of the joints, a pectus deformity, but unlike Marfan's, they can have cognitive delays, downward dislocation of the lens. So in Marfan's, it goes up. In homocystinuria, it goes down. And the risk of blood clots can result in ischemic stroke and pulmonary embolism. So patients with Marfan's can get a pneumothorax, but patients with homocystinuria can have pulmonary embolism. So I'm going to go through a bunch of different cases, and then we're going to go through the metabolic disorders. So a 12-day-old, about 2 weeks old, presents after discharge from the nursery. He was born full term without any complications to a 32-year-old first baby. All serologies were negative. The mother states the baby's having difficulty breastfeeding, and she wonders if she should change to formula. She notices he throws up a lot and his urine has a sweet smell. The baby has lost 7% of his birth weight. Well, he's 12 days old, so he's not yet 2 weeks, and he lost 7% of his birth weight, so that's not horrible because you're allowed to lose up to 10% by 2 weeks. So, and the exam is fine, so you reassure mom, keep pushing with the breastfeeding. And 4 days later, the baby presents to the ER unresponsive, hypertonic, and starts to have a convulsion. So, oops. So anyway, we get some labs. So let's look at our labs. Our blood pH is 7.34, so a little low, and the HCO3 is 15. So it looks like we're going down this way, and where is the acid coming from? Well, the ammonia is 180, and the lactic acid's 1.4. So it's less than 2, so it's probably not coming from lactic acid. It's a little, and the glucose is 70, so a little hypoglycemic. So it's probably coming from somewhere over here. So this is actually maple syrup urine disease. Babies usually deteriorate in the first 1 to 2 weeks of life. The ammonia can be normal to mildly elevated, and it's usually mildly elevated because the liver's kind of mad. The lactic acid's normal. Glucose could be normal to mild hypoglycemia, and there's a maple syrup or sweet smell to the urine or the earwax. Serum amino acids will show elevation of branched chain amino acids. Leucine, isoleucine, and valine, and alloisoleucine is pathognomonic. I love Vermont maple syrup is a mnemonic for this. And it's inherited in autosomal recessive fashion. It occurs in 1 in 100,000 to 1 in 300,000. But it's 1 in 200 in the Mennonites. So the actual presence of maple syrup urine is 1 in 200 in Mennonites. So this is like a founder effect gene. Maple syrup urine disease is caused by a non-functional enzyme in the branched chain ketoacidosis complex, or BCKD, which catalyzes the decarboxylation of alpha keto acids, leucine, isoleucine, and valine to their acyl-CoAs. The elevation of isoleucine results in the sweet smell to the urine. I spelled that wrong. Management is low protein diet with limiting branched chain amino acids. Urea cycle. The purpose of the urea cycle is to get rid of nitrogenous waste and to make arginine. When this cycle is not working correctly, ammonia is elevated, and the incidence of urea cycles is about 1 in 30,000, with X-linked ornithine transcarbamylase being the most common. So let's look at the urea cycle. Here we have ammonia, and we want to release it in a water-soluble form of urea. So the ammonia combines to carbonyl phosphate, and then it goes into the urea cycle. And this first step, going from ornithine to citrulline, is by the ornithine transcarbamylase. Citrulline then goes to original succinate, and when this enzyme does not work, and this is actually known as original succinate synthetase enzyme, then as a result, the citrulline gets very high, and that's why it's known as citrullinemia. Original succinate lyase deficiency is going from original succinate to arginine, and when that can't happen, then the citrulline is elevated, and then arginine goes to ornithine and releases our water-soluble urea. So if we actually look at citrulline is on the amino acid, so if it's low, you think of OTC. If it's elevated, you think of one of these. Arginine is low in these first three, and it's elevated in arginase because it can't, so it can't get to arginine if there's a deficiency of the original succinate lyase or the original succinate synthetase or even OTC. So the arginine, so in OTC, citrulline will be low, arginine will be low. In citrullinemia, citrulline will be very high, arginine will be low. In this one, citrulline will be elevated because it can't push this way, and arginine will be low, but then when you get to arginase, arginine will be elevated. So, isovaleric acidemia, sweaty feet, maple syrup urine disease, sweet smell, phenylketonuria, mousy, and tyrosinemia, rotten cabbage. These are just, again, if you read an exam question, they tell you about urine smells or the smell of the baby or something, like look at this, like think about why they're telling you this. Okay, a baby boy is born by C-section. The first day of life, he's nursing well at 36 hours of life. So the first one, the baby was almost 2 weeks. This one's 36 hours. He's now hypotonic, lethargic, and his blood gas is 7.49. So it's actually elevated. And this HCO3 is 26. Septic workup, including CBC and LP, are normal. The ammonia is 1500. So we're actually not going here. We're going down here. We're going down to the urea cycle defects. So pH is 7.49, CO2 is 26, ammonia is 1500. So symptoms of a urea cycle is the ammonia is very high and these babies look horrible, but they're not acidotic, they're alkalotic. The ammonia can reach thousands. So the most common is OTC. The serum amino acids is needed to determine which enzyme is abnormal. In OTC, urine organic acids will show an elevation of something called orotic acid, and amino acids with OTC will show low citrulline. Late presentation. So some of these disorders present a little bit later. An 18-month-old female has been growing and developing well, except for 2 episodes of vomiting and dehydration at 9 and 12 months of age. They were both thought to be caused by a viral illness. On admission, she's dehydrated and unresponsive except for grimace to stimuli, and her tone is increased. So, laboratory values. She's super acidotic. The HCO3 is less than 5, so we're definitely kind of going down this way. The lactic acid is 1.2, so it's not coming from lactic acid. And the ammonia is 120. Again, the liver is not happy, but it's not in a urea cycle stage. So this is glutaric aciduria. Glutaric aciduria is babies have a large head. Often they have a normal development until their first episode. And some have profuse sweating and unexplained fevers. But even though they have a large head, they can have actually macrocephalic microcephaly. So there's an elevation of glutaric acid in the urine organics. An MRI can show lesions to the basal ganglia and subdural hematomas. The glutaric acid is toxic to the brain, and it results in brain atrophy and yet extra fluid around. So it's a microcephalic macrocephaly. So the head is big, but the brain is small. And it's that change in the size that causes tearing of vessels that can cause these subdural hematomas. It's the most common cause of subdural hematomas, though, is child abuse. So oftentimes I would be called, there's a baby with subdural hematomas, and if they also have retinal hemorrhages and fractures and breast skull fracture, it is probably not a metabolic disease. But it's also not a bad idea to send urine organic acids just to be certain of it. However, if this is the baby that had macrocephaly before all this happened and some other kind of issues, then, and no other signs of any, how did this kid, it looked septic and it came in obtunded and now we're finding the subdurals, that's when you should think about metabolic. So a baby has 4 days of life with lethargy, decreased PO intake, and the septic workup is negative. He's noted to have a blood gas of 7.49, ammonia of 1200. What is the most likely diagnosis? Ornithine transcarbamylase deficiency, maple syrup urine disease. We can talk about MCAD in a little bit, galactosemia or PKU. And the answer is this is a urea cycle. And the only one here that's a urea cycle is OTC. You will not be asked to be able to differentiate between one urea cycle and another. As long as you know the common things. When you read these questions, there'll be 3 or 4 possible answers, clues to the correct answer. A 6-month-old presents to the emergency room with lethargy. He's diagnosed with a viral illness 3 days prior. He had poor PO intake for 2 days, and the laboratory study showed glucose of 50, a blood gas of 7.38, CO2 of 21, and the lactic acid's 2.5. Ammonia is 80. The urine dip is negative for ketones. The most likely diagnosis is ornithine transcarbamylase, maple syrup urine disease, medium chain acyl-CoA dehydrogenase, or MCAD, galactosemia, or phenylketonuria, or PKU. So next we're going to talk about fatty acid metabolism. So medium chain acyl-CoA deficiency, dehydrogenase deficiency, or MCAD, occurs in about 1 in 6,000 individuals. It's inherited in autosomal recessive fashion. And the enzyme is involved in the mitochondrial beta oxidation. Symptoms usually occur after prolonged fasting. And their presentation is hypoketotic hypoglycemia. When you have hypoglycemia, your liver should be making ketones. You should have ketones in your blood if you have low glucose, because ketone bodies are a way to get some type of energy to the brain. So if you do not have ketones when you're hypoglycemic, that's abnormal. Organic acids in acylcarnitine studies show an increase in C6 to C10 dicarboxylics, which I'm going to explain what that is in a second. And 2 to 3% of babies with sudden infant death or SIDS result from MCAD. The way they came to this number is before we actually do study this on the newborn screen, but prior to that, they went to the 2 or 3 states and they pulled all the newborn screen cards from all the babies in those states that had died of sudden infant death. And they tested them for MCAD, and they found out that about 2 to 3% of them actually had that. So what happens? The baby is sleeping over the night. Maybe they have a little mild virus, and that increases their metabolic needs. And they're not eating. And so normally, the liver starts breaking down fats. That's why we have fats. We store them. Some of us store more than others, so that when we need them, we can use them. But we can't get them, and there's no other way to get energy, so the glucose starts dropping, and then the respiratory center stops, and then the baby stops breathing. So let's talk about fatty acid oxidation disorders. So fatty acids are used for energy in the citric acid cycle, and the way that we use them is we glob on carnitine to our fatty acids to allow it to be transported into the inner mitochondrial membrane. And when carnitine is attached to a fatty acid, it's known as an acylcarnitine. And so this acylcarnitine then goes through beta oxidation. It goes from 16, 14, 12, 10, 8, 6, 2, 4, 2, and once it gets to 2, now the carnitine's freed up and it goes back to get more. And each of these 2 carbons go through into the citric acid cycle to make energy for the cell. So there are a number of fatty acid oxidation disorders, very long chain dehydrogenase. This actually occurs in the peroxisomes before we get to the lysosomes. In the peroxisomes. So this is known as Velchad, and then it gets to C16, and then it ends up in the mitochondria. This would be an elevation of C16, elevation of C12, elevation of C8, elevation of C2. So LCHAD is 12 to 10, MCAD is 8 to 6, so this gets elevated, and this is the last stage. They are not even sure that this is actually a disorder. So MCAD deficiency is the most common of the fatty acid oxidation disorders. It wasn't even described until 1983. And treatment is carnitine supplementation. Why is that? Well, the carnitine gets stuck onto the acyl species, so it doesn't get freed, so it ends up deficient. And you need to keep bringing carnitine is the only way to get these fatty acids into the inner mitochondrial membrane, so you need some extra carnitine. A low-fat diet. If you can't break down fats, you shouldn't eat them. For instance, a ketogenic diet would be a really bad idea for somebody with fatty acid oxidation disorder and preventing fasting. Usual presentation, again, an episodic illness, a mild viral illness that increases your metabolic needs a little bit. Between 3 months and 2 years, usually following fasting for 12 or more hours and an incurrent infection. Again, the baby's not eating as well, it's tired, it goes to sleep. Acute episodes often start with vomiting or lethargy or even seizures and can rapidly progress to coma because the brain gets really mad when it doesn't have sugar or any other energy source. Symptoms include hypoglycemia, but again, when you're hypoglycemic, you should have ketones. That's our body's way to bring energy to the cells, to break down fats in the liver. Hyperammonemia, high uric acid, high CPK, and the high CPK, the muscles are really pissed off now because they don't have any energy either. So, a 6-month-old presents to the ER. He's diagnosed with a viral illness 3 days prior. He had oral intake for poor oral intake for the past 2 days. Laboratory studies show glucose at 50, blood glucose at 7.38, CO2 at 21, lactic acid's 2.1, ammonia is 80, and the dip is negative for ketones. And again, that's the most important thing. So you got a hypoglycemic kid, no ketones. And the correct answer is MCAD. So if it were ornithine transcarbamylase, this would be super high. If it was maple syrup urine disease, the baby would be acidotic. And if it was PKU, actually none of these things would be going on and they wouldn't present this way. So the next thing we're going to talk about is sugar metabolism. A newborn begins to vomit after feeding and is jaundiced. The treatment for possible sepsis is initiated and a blood screen for galactosemia is positive. Which of the following studies would be expected? Urine amino acids will show an elevation of phenylalanine. Urine organic acids indicate elevation of branched chain amino acids. Ammonia is elevated. Urine is positive for reducing substance, or a blood culture is positive for streptococcus. So now I'm going to talk about glucose metabolism problems. And the first thing I want to talk about is galactosemia. And galactosemia results in the inability to convert galactose to glucose, because we can't really use galactose. So we got to convert it to glucose, and there's actually 3 enzymes, but one's the most important, which is GALT, galactose 1-phosphate uridyl transferase. So there's 3 enzymes, GALT, GALT, and GAL. These are very rare. This is the most common. They're all recessive. When galactose cannot be converted to glucose, then it's sitting around, and it has to be converted to glycotrol, which is actually toxic to the liver and the brain. And The other problem is, and so this results in accumulation in the eye and cataracts, and this unmetabolized sugar is known as a reducing substance. It gets excreted into the urine, and the other thing is elevated galactose. E. coli likes to eat it, which we're going to talk about in a second, and it's inherited in autosomal recessive. So features include jaundice, hepatomegaly, vomiting, and feeding intolerance, E. coli sepsis. Again, galactose loves E. coli, not streptococcus, but E. coli. Cataracts, and untreated babies, they can progress rapidly to toxicity from death from sepsis or bleeding. Treatment, a lactose-free diet. If you can't break down lactose, don't give it in the diet. During infancy, a soy formula instead of Similac or infant milk. But one of our biggest problems is that breast milk has lactose. So oftentimes, as a pediatrician, you get called on Friday afternoon at 4:30 that one of your babies has an abnormal newborn screen. We're never going to ask you specifically what's on a newborn screen, but just to understand, we like to pull in 50 babies that actually don't have it to miss one. So we have a very high false positive rate. But the problem is you don't know which baby has the false positive, and breast milk has lactose. So this is one of the few times I would call a mom, because this could cause this baby to be dead by Monday. So you got to call Friday evening, and believe me, it's not a fun call because you got these new parents. And you just have to tell them, the newborn screen was abnormal. It's probably a false positive, but I want you to switch to lactose, pump, and store. And if it turns out the baby doesn't have galactosemia, you can go back to breastfeeding. If it does, we can't. So, a newborn begins to vomit after feeding and is jaundiced. Treatment for a possible sepsis is initiated. A blood screen for galactosemia is positive. Which of the following studies would you expect? Urine amino acids will show elevation of phenylalanine. Urine organic acids show elevation of branched-chain amino acids. Ammonia is elevated. Urine is positive for reducing substance. Or blood culture is positive for streptococcus. So this is a scenario of galactosemia, and there's reducing substances in the urine, and the blood culture could be positive for E. coli, but not streptococcus. Now we're going to talk about glycogen storage disorders. And glycogen is another method to store sugars. And so we store them into large, branching chain things. And so this is a group of disorders characterized by non-functional enzymes either in the breakdown or the synthesis of this large glycogen, which is how we store our sugars. The hallmark of this disorder is the accumulation of abnormal amounts of glycogen in tissues such as liver and skeletal muscle, and unfortunately it's a relatively uncommon disorder. So a college student comes to clinic. He recently started a weightlifting program. After 30 minutes of workout, he experiences severe pain, which has not improved over the past week. The day prior, he had a red color to his urine. The urine dip was negative for blood. A CK was noted to have an elevation to 6,000, normal 30 to 100. What is the most likely diagnosis? Becker's muscular dystrophy, medium chain acyl-CoA dehydrogenase deficiency, or MCAD, galactosemia, citrullinemia, or McArdle's disease. So here are these branches of this this is how we store glucose in this big branchy thing called glycogen. And the thing is, we need to break down to glucose something usable. And that's, where all these enzymes come into place. So type 1 von Gerke's is one of the last steps going from glucose 6-phosphate to glucose. Type 3 debrancher is up here. We got the debrancher and the branching enzymes, liver phosphorylase. But let's first talk about type 1 glucose 6-phosphatase deficiency, or von Gerke's. This usually presents between 3 and 4 months of age. You get this big liver. I mean, look at this belly, but the baby actually has failure to thrive. Look how thin the arms and legs are. The cherubic cheeks, hypoglycemia, and seizures. And so on labs, you'll see hypoglycemia, lactic acidosis, hyperuricemia, and hyperlipidemia. The liver is trying to make some kind of energy so the lipids are high. Treatment: prevent hypoglycemia with continuous feeding and restrict lactose and fructose from the diet. So von Kerkes, or glucose 6-phosphatase deficiency, when the blood glucose is low, the body breaks down glycogen. And so part of the reason we want the treatment is we don't want the body to be making glycogen or breaking it down, because we can't do that. So glycogen is converted to glucose 1-phosphate, which is then goes to glucose 6-phosphate, and then our problem is we can't go from glucose 6-phosphate to glucose, so we end up going to pyruvate. So the pyruvate is elevated as well. And this is the enzyme that's abnormal in von Kerkes. As a result, this elevated pyruvate also results in elevated lactic acid and hyperuricemia in the citric acid cycle. So that's the reason for all the rest of these abnormalities. Type 3 debrancher, like I said, there's these big branching things. Von Kerkes is the last step, but this is an earlier step of getting, taking these branches off so that then we can further metabolize them and get our glucose back. And when these enzymes are not present, these glycogen they get larger and larger, and we can't break them down. And so we have a big liver, hypoglycemia because we don't have the sugar, short stature, skeletal myopathy, and cardiomyopathy, because these large glycogen conglomerations end up taking over the muscle, and the most important muscle in our body is our heart. So type 2 Pompe's disease, we already discussed the lysosomal storage disease as well as a glycogen storage, so I talked about that in the lysosomal storage. Type 5 McArdle's, and type 7 phosphofructokinase deficiency. So McArdle's is a deficiency of the enzyme muscle phosphorylase. The PYGM gene codes for this enzyme, and it's a recessive, and absence of this enzyme results in decreased ATP by glycolysis. Symptoms usually begin in the early 20s, so it occurs a little bit later. Exercise-induced muscle cramps and exercise intolerance is a really common symptom, and they have this red-colored urine, but it's not blood. CPK can be elevated, sometimes to the thousands, and this is known as rhabdomyolysis. And so muscle biopsy can identify glycogen deficiency, although we're trying to go with a less invasive test of a DNA, which is like 100% identifying mutation. Treatment is to avoid strenuous exercise, IV fluid, and glucose during times of rhabdomyolysis. Phosphofructokinase deficiency, this is the lack of the enzyme fructose 6-phosphatase, and it's very similar to McArdle's, although it can occur a little bit earlier. So here's the phosphofructokinase deficiency. Differences: it occurs in childhood. Hemolysis can occur, very high levels of lactic acid, and exercise intolerance is worse after a carbohydrate meal, which a lot of people do before they go on a long run. So a college student comes to clinic. He recently started a weightlifting program. After 30 minutes, he has severe pain, which has not improved in the last week. The day prior, he had red-colored urine, but it was negative for blood, and the CK is 6,000. What's the most likely diagnosis? Becker's muscular dystrophy is a muscular dystrophy that would show an elevation of CK, but it probably would not be a college student doing a muscle workout. Medium chain acylcarnitine deficiency. This is a problem with fatty acid oxidation, and you might see hypoglycemia, but you wouldn't see red-colored urine or an elevated CK. Galactosemia, again, is you'd see hypoglycemia. Citrullinemia, you'd have an elevated ammonia, and then McArdle's disease is more, with this scenario. So, try to put metabolic disorders into categories. Try to categorize them by the most common differentiating feature. If they're telling you what the urine smells like, think about it. If they're telling you, that the person's a certain ethnic background, think about it. Most newborn screens, like I said, include all of these, but we're not going to ask you specifically about they might tell you a newborn screen showed something, but they're not going to ask you questions about the newborn screen. So I pulled a bunch of USMLE questions, and we're going to go over them. A 24-year-old woman has phenylketonuria, has her first child. Although there was no family history of PKU in the father's family, the baby is born with microcephaly and an elevated level of phenylalanine at birth. What's the most likely cause? The baby has PKU. The baby is a carrier of a mutant enzyme for phenylalanine hydroxylase. The father has PKU, or phenylalanine was not adequately restricted in the mother during pregnancy. What is the most likely cause for the microcephaly? Okay? The baby has PKU. Well, I suppose that's possible, but probably not. It's definitely a carrier of PKU, but the father doesn't have a family history of this, and babies are not born with microcephaly. It's progressive, so that's probably not why they were born with microcephaly. The baby is a carrier of a mutant enzyme. Well, they definitely do have one copy, but they probably don't have two. The father has PKU. Well, there's no reason to believe this, and the phenylalanine was not adequately restricted in the mother during pregnancy, and this is the correct answer. Again, I took this out of a book. I may argue that I would have written it a little bit different. I'm just showing you when asked questions about PKU, this is the kind of questions when I go through these books that I really see the most. The condition from the pedigree has a prevalence in the population of 1 in 40,000. What is the chance the affected individual shown by the arrow will have an affected daughter? This is a little bit of a different genetic question, but I just put it in here anyway. So the inheritance, you got male-to-male transmission and 3 generations, so it's not X-linked. It's got to be dominant. And if he has a dominant disorder, what's the chance his daughter will get it? And that is 50%. A 9-year-old female has mild mental retardation. She was healthy at birth. She presented in the first week of life with vomiting, lethargy, and seizures. The amino acid screen identifies elevation of leucine, isoleucine, and valine. The baby was placed on a special diet. She has no medical complications since that time. What enzyme's most likely deficient? So they don't tell you what it is, but they tell you that there's an elevation of leucine, isoleucine, and valine, and she presented in the first week of life. So these are branched-chain amino acids. So this is maple syrup urine disease or branched-chain ketoacidosis dehydrogenase. Really mean question. Anyway, a 2-month-old is evaluated for failure to thrive. During the examination, the child has a seizure. Stat serum chemistries demonstrate severe hypoglycemia, hyperlipidemia, lactic acidosis, and ketosis. Physical exam is remarkable for hepatomegaly confirmed by CT scan. Which of the following best represents this? Gaucher disease, McCardle's, Niemann-Pick, Pompe, or von Gerke? So we got a 2-month-old with failure to thrive. And this is von Gerke's. So we got 2-month-old failure to thrive, hypoglycemia, hyperlipidemia, ketosis, liver is enlarged. So Gaucher, you might have a liver enlarged, but you're not going to have hypoglycemia. McCardle's, as I said, presents later. Niemann-Pick, you could have hepatosplenomegaly, but it usually does not present with hypoglycemia. Pompe disease, you might have severe hypotonia, but you're not going to have ketosis and lactic acidosis. And so this is the only correct answer. And that concludes this presentation.